obviously things happening incredibly quickly here, and I thought that in addition to just a bit of an update on Omicron, it might be helpful to talk a little bit about some of the data that's coming out from flu recently and the prospects of having a confluence of influenza and COVID in the coming months. So if we look at Omicron data now, there's certainly conflicting data about what the impact of an Omicron wave is going to be and the severity of such a wave. I think that it's helpful to look at South Africa, which again was the epicenter originally and has the biggest head start on the rest of the world. And that's important because this Omicron virus moves so rapidly through populations that the timing of how we expect to see different effects like hospitalizations and deaths may be affected. And so again, this early exuberance that people have had about lower lethality and potentially lower rates of severe disease, hopefully we dispelled some of that exuberance on Tuesday, talking about just what happens with the sheer numbers of a virus that transmits so much more readily. But I think the South African data are now potentially starting to catch up and show that effect. So you see that it appears that at least in Gauteng province, again, the province which has Johannesburg and Pretoria in South Africa, and where the epicenter has been for Omicron, it appears that Omicron cases may be peaking, or it may be that Gauteng's testing capacity has been saturated. And so you're just not seeing increasing numbers, even though case counts may be increasing. Nevertheless, when, again, you look at the difference between the rate of growth with Omicron and Delta, it is dramatically different. It has taken Omicron less than 30 days to get to the same point that it took Delta 60 days to get to. But if you also look at hospital admissions and deaths, Omicron appears to be keeping pace with what you would expect, relatively speaking, compared to Delta and the other virus strain epidemics that they've experienced in South Africa. Now, perhaps the slope has dropped off a little bit compared to cases, but the bottom line is we're not seeing a huge decoupling of cases and hospitalizations as we've seen in the UK with Delta. And again, that's not only deaths, but I'm primarily worried about hospitalizations because that is an indication of health system impact and whether our health system is going to be overwhelmed by Omicron. Now, in the UK, we haven't seen a significant rise in hospitalizations yet, but the latest data that comes out of the National Health Service in the UK is 5 days old, and things are moving so rapidly, again, with a doubling time of 2 to 3 days, that even the case curves really are just starting to show the significant impact of Delta. So that big spike is the 14th of December, and that's probably the first indication of significant impact of Delta on their case curve. And so it just may be we haven't had enough time to see that impact in hospitals. So I'm still very worried about what's happening in the US. We're seeing massive growth rates that parallel what we observed in South Africa and the UK. It appears that in the US, Omicron is probably also doubling close to every 2 to 3 days. And so we're going to see the impact of this virus very soon if we're not seeing it already. And in fact, I think we are in a lot of the clusters and new outbreaks that are occurring. Now, this, as we've discussed, is occurring in the background of what's probably going to be a relatively normal flu season. And unfortunately, the data for the flu season are looking more and more concerning, that this may be potentially a worse than average influenza season if all things are equal. So here are the data most recently from the CDC's flu surveillance network, showing that influenza cases, laboratory confirmed influenza cases, are indeed on the rise. And this is tracking along with what we see with a typical influenza season. primarily flu A, which is what we would expect in the fall wave most of the time. And most of these flu A viruses are H3N2. H3N2 years tend to have higher hospitalization and mortality associated with them compared to years where H1N1 has dominated. And so that portends potentially a bad flu season as well. So there is H3N2, that's the predominant virus that's being detected right now. If we look at the influenza vaccine composition for this year, you can see that the quadrivalent flu vaccine, which is kind of the traditional typical vaccine that we have now every year, uses this Cambodia H3N2 virus that is one that's been circulating for a couple of years. And this is something, again, I think we've discussed, but it's an educated guess every year what viruses go into the flu vaccine. And some years there's a good match, and some years the match is not so good. For this particular vaccine, again, for H3N2, it's this virus, and flu virus nomenclature is, if possible, more confusing than coronavirus, but it goes by multiple names. So you can also see this H3N2 3C, 2A1B, 2A1, aka 2A1 virus, which is the current flu vaccine. Now, this just came out from some folks at the University of Pennsylvania in Scripps, looking at potentially signs of poor match of the flu virus this year with what are current circulating strains. So you can see that 2A1 is what we talked about, the Cambodia virus that's in the current vaccine. But there is now this emergence, as you see in the arrow, of a new lineage of H3N2 that they've dubbed 2A2, that kind of branched off from the progeny virus of the 2A1 not too long ago, but that seems to be taking off and becoming the predominant strain. Now, this is important because there are a couple of key mutations, one of which is in a important part of the hemagglutinin antigen. So this is the hemagglutinin antigen protein structure on the right. This is somewhat analogous to the spike protein of the coronavirus. It's where the virus binds to its host cell in the respiratory epithelium and gains entry. And the mutation, one of the mutations specifically between 2A1 and 2A2, affects how sugar is attached to the HA protein, and therefore how well it binds to its receptor on the respiratory epithelium and gains entry. What is also interesting and more confusing about flu vaccines is not only do we have to worry about that wild type virus that the flu vaccine is based on, that's the 2A1 wild type that you'll see here to the right of this arrow, but we also have to worry, are there differences between that virus and ultimately the virus that gets put into most of the vaccines, which has to be egg adapted. So most flu vaccines still are grown in eggs, and to grow the virus in eggs, you actually have to do some passages to adapt the virus to grow better in eggs. And sometimes that creates changes in the virus that can affect its binding and immunogenicity, and that appears to be happening this year. So that arrow is pointing to the neutralization titer from 40 volunteers in pre-vaccination serum, showing that for the egg-adapted virus, their titers are actually higher, so they have better binding antibodies against that egg-adapted virus than they do actually against the wild-type virus. Now, why would people have any antibodies at all? It's because they've been infected with an H3N2 strain in the past, right? So even though it may not have been this particular flu strain that's circulating this year, there's enough cross-reaction to give you some protection. Just like, you know, if you were infected with the original Wuhan virus, you probably have some cross-binding antibodies and protection against Delta and Omega. It's just probably a lot less. So what we're seeing is, first of all, the egg-adapted virus, your immune response against that virus actually seems to be a lot better even before the vaccine and after the vaccine than your antibody binding to the wild viruses, the ones that are actually circulating in the population and making you sick. Now, the antibody binding is even lower for the 2A2 wild type, right? That's that new mutant that started circulating recently. And you can see here that where the arrow is pointing to, it's talking about that fact that neutralizing antibodies against wild type are low, even after vaccination. And that's true against 2A1 and 2A2, but they're worse against 2A2. And you can see in the bottom quote, 10-fold lower, comparing the new 2A2 H3N2 strain compared to the egg-adapted 2A1, which is what the vaccine is based off of. And so this points to the fact that it's probably going to be a poorly matched year, or immunity from the flu vaccine is going to be worse, and probably more of a problem and worse for people who get one of the egg-adapted vaccines versus a couple of the flu vaccines are actually made in recombinant cell expression systems. So there may be actually a difference between the vaccines on the market for protecting against flu. And that's what that top quote discusses. At the end, they also want to reinforce that even in years where flu vaccines are poorly matched, you still get significant benefit in terms of reducing overall hospitalizations and mortality from flu vaccination. So it doesn't mean that flu vaccination is worthless and isn't going to do any good. It's still critically important, but it just may mean that we're going to have a more severe flu season this year than we might expect with a well-matched vaccine. And we're right now seeing our influenza season again tracking along with what regular seasons have looked like. Those arrows indicate this current influenza season, and this is the curves of influenza-like illness that are being reported. That large arrow is just reinforcing that. And so if we track along with other typical years where we seem to be tracking with now, we can expect that our flu season will probably peak sometime in January or potentially as late as February in that window of time where I've highlighted there. So looking ahead, if we're going to see Omicron start to really explode on the scene over the next couple of weeks, this creates this issue of confluence around the beginning of January, where we're seeing a massive peak in COVID because of Omicron. We already will have experienced this huge surge of Delta, and whether Delta and Omicron will coexist or whether Omicron will just replace Delta, I don't think anybody can accurately predict at this point. I think the latter is probably more likely, but we'll have to wait and see. But this is going to occur at the same time as we're peaking with influenza. So as you all know, during a regular influenza season, our hospitals are already full and overflowing in January and February. No idea how we're going to accommodate both of these things happening together. That's all I have. Thanks, Shelley.